I'd be delighted to. I feel we are so fortunate to have Dr. Jerome Adams with us this evening on this topic of COVID that we're all kind of like, well, that was in the past. And yet I know people that have recently gotten COVID and some people that still wear masks for a variety of reasons. I think we're still kind of trying to figure it all out. But Dr. Adams had served as the Indiana State Health Commissioner prior to being named the 20th U.S. Surgeon General in the President Trump's administration, where he served on the Corona Task Force and was operational head of the 600-person Public Health Service Commissioned Corps and oversaw responses to 3 back-to-back Category 5 hurricanes. I met Dr. Adams last summer when he received the Founding Dean's Award for Excellence for IU Fairbanks School of Public Health and was a good friend and a colleague of the founding dean, Paul Halverson, who was my neighbor. And I've continued to follow Dr. Adams as he is a regular communicator on TV, radio, and in print, and is an expert in science, making it relevant to several audiences. He's a licensed anesthesiologist who holds a master's degree in public health in addition to his COVID work. He's assisted organizations so they may navigate opioid epidemic, maternal health, rising rate of suicide, and a variety of other issues. In 2021, he was appointed a presidential fellow and the executive director of Purdue's Health Equity Initiative, and he is a distinguished professor of practice in the departments of pharmacy practice and public health. I am so pleased to hear Dr. Adams on to discuss this really relevant topic. Thank you.
Well, thank you so much, Sue, for having me. Thank you, Ray and Betty, and thank you to everyone else who's a part of this conversation. And I do want this to be a conversation. I want to start off by apologizing. I am facing west, so as you all can see, the sun is shining on one side of me, and throughout our conversation, I'm thinking it's going to continue to move across my face. So I hope you can see me. I want folks to be oriented to kind of the way this is going to go. I'm going to give some introductory remarks, probably about 10 minutes or so to frame things. And then we're going to go with some structured questions, and then we're going to open it up for Q&A. And like I said, I want this to be a conversation. So setting the stage for this conversation about pandemic preparedness. I asked myself, what was the most important thing I could say to you all, or story I could tell you? And I kept coming back to October 20th of 2020. And why do I keep coming back to that date? Because that was the date of the last presidential debate between Joe Biden and Donald Trump before the 2020 election. And in that debate, Joe Biden said of about 40 or 50,000 deaths that had occurred at that point during the pandemic, that anyone in the United States, that anyone who presided over that many deaths should no longer serve as president of the United States. And you can look this up. You can easily find it. And why do I highlight that? Well, I highlight that because the last election was really defined around different perceptions of how the pandemic was handled. And that's fair. That's fair. But I will say that when you fast forward to 2021, at the end of 2021, if you ask yourself how many deaths occurred under the new administration, it was well over 300,000 deaths. And so why is that important? it's important for us to understand that, because the premise that changing the president, the FDA commissioner, the Surgeon General, the CDC director was going to change our COVID outcomes has been proven false. And it's not to say that this is Joe Biden's fault. It's not to say that that Donald Trump did a great job, but it is to say that we now have clear evidence that there's something deeper going on. And if you go fast forward even beyond that, because let's say it takes a year to get into a groove. You fast forward to 2022, and there were still more deaths that occurred in 2022 with vaccines, with PPE, with treatments like Paxlovid that occurred in 2020, at which time Joe Biden said any president who presides over this many deaths should resign. And so we're going into a time now where we're going to relitigate a lot of that, because we've got the exact two same candidates that we had before. And I think it's important for people to understand the underlying issues that really caused us to have the terrible outcomes that we had in 2020. And make no mistake about it, far too many people died. And what caused more people to die in 2021, despite having vaccines, treatments, PPE, and what caused still far too many people to die in 2022, and why we still have 1,000 people dying every week, in many cases preventable. And so it's why I wrote my book. It's called Crisis and Chaos, Lessons from the Front Lines of the War Against COVID-19. And it's really about putting us in a position to understand what actually happened and how we can all do better next time. And so I'm going to spend the next 5 minutes before we get into questions, quickly going through the 10 lessons that I have in the end of this book that I think are incredibly important. I'm not going to go into detail. The book is on Amazon if you want to check out the book. And I actually think it's a pretty fun book to read. I say fun because I tell stories. I try to walk people through what it was like to be in the situation room, to be the person having to make many of these consequential decisions. And it's easy for us to forget. We block out that at this point in 2020, we still were scared to bring our groceries in the house. We didn't know if it was safe to bring in the mail. We were still hoarding toilet paper. There was a lot that we didn't know. And in hindsight, it's easy to say, well, that was stupid. Well, why'd you do that? Or why didn't we do that? But in the moment, we were making decisions in real time with limited information in an incredibly contentious environment. And so now I'll quickly go into those lessons, because lesson one is that we have to take the partisanship out of public health. So much of the way we viewed decisions during the pandemic and still now in regards to COVID aren't about whether it makes scientific sense or not. It's about whether or not it's a Democratic idea or a Republican idea, whether it's something Donald Trump endorses or whether it's something Joe Biden endorses. And an example of that, again, as I mentioned, was that a smaller number of deaths in 2020 was considered disqualifying for serving as president. And then in 2021, when it was a different president, many of the same people said, well, that's fine. It's no longer about how many people died. It's about something else. And so we have to take the partisanship out of public health and look at these things objectively, and in a way that's actually going to help us have important conversations. Lesson number two is that science and health literacy must improve. So one of the reasons it was so hard to have really fulsome conversations was because the U.S. ranks pretty poorly nationwide in math and science literacy. 19th in science, 13th in math. And that makes it really difficult to have conversations with people about emerging data, about statistics, about understanding that, hey, a 99.5% survival rate times 350 million people is still a heck of a lot of people dying, and we shouldn't just dismiss it. And then when you multiply that number by the number of people who are hospitalized, or the people who have long COVID, that it is an incredibly large and impactful number on our societies. So we have to start in grade school and really help people understand the scientific process, that science isn't about knowing the 100% truth of everything all the time. It's about the pursuit of truth, and that sometimes you've got to adapt on the fly when you get new information. Lesson number 3 is that we have to address the problem of misinformation and disinformation. So another thing that was incredibly hard for me and for everyone during the pandemic is that once upon a time, if the Surgeon General of the United States said something, it was accepted that, hey, there's good scientific evidence behind it. We should listen to it. I was competing with Joe Rogan. I was competing with movie stars and celebrities who had their own opinions. And there was a lot of, and I was also competing with Russia and China, who were actively putting out misinformation and disinformation to sow discord. And we've got to figure out how to combat misinformation and disinformation that's causing people to not trust government, to not trust science, and to act in ways that are against their own self-interest. Number 4, we need better data, and we need it more quickly. So a story that I tell really quickly is about when the president asked me how many people were infected with COVID. And I said, I don't know, Mr. President. And he said, well, how many beds do we have in the hospital available? I said, I don't know, Mr. President. I said, how many ventilators do we have? I said, I don't know, Mr. President. And then he said something not so nice to me in typical Donald Trump fashion. But I tell you that story because we were literally driving the car down the road at night with the headlights off and waiting until we hit a speed bump or a dead body in the road in a very real sense before turning the wheel. Because we didn't have the data to make informed decisions. It's hard to make good decisions without good data. And we can talk a little bit more about that later in the Q&A if you all want. Lesson 5, we need to rethink and restructure our federal public health emergency response system. And again, we can go into this if you want to, but it's clear the CDC in many ways failed us. And there are reasons behind that. Some of them are that the CDC was not funded or equipped or designed to make quick decisions and to communicate them to the public in a crisis. Lesson number 6, public health officials should not underestimate the value of relationships when dealing with health crises. And the quick story I tell about this is how drastically all of our views of the pandemic changed when we got outside of Washington, D.C. And when we started talking to people on the ground, and we started to hear their real concerns and fears about losing their jobs, their livelihoods, about their kids not going to school. It's really easy when you're in a bubble to say we have to do everything possible to prevent the spread of a disease. But when you get out there and you realize that there are people being harmed because of the mitigation measures we're putting in place, then that makes it real for you. Lesson 7, we need better messaging and infrastructure and the resources to support it. So I talked about the CDC. I was the Surgeon General of the United States. I was working 16 to 18-hour days. And at the same time, I was composing my own tweets on social media and coming up with my own messages for the media. There is no one in the private world who has the responsibility that I had when I was Surgeon General, who is out there doing their own social media. We need the infrastructure and resources to help people in my position craft messages that are appropriate for the public and that take into account all the different ways that message could fall flat on certain audiences. So Tony Fauci, others, we were communicating in good faith with the information we had at the time. But the truth is, there's a reason why there are communications degrees. I have a medical degree. And people don't want to hear me or Dr. Fauci out there, talking in scientific speak. They want us to make it real for them. And we need help with that in the future if we want to do better. And you saw that, again, once you got everyone out from 2020 and replaced them with all new people, they still had these same communications challenges and issues. They still kept saying things that fell flat with the public. Lesson 8, we can't be a healthy nation without health equity. What do I mean by that? I mean, the people who were most impacted by the pandemic are the same people who have the highest cancer rates, the highest diabetes rates, the highest drug overdose rates. And that is not a coincidence. We continue to forget about the marginalized and under-resourced communities, Black and brown communities, the people who are our frontline workers were in many cases, again, the same people who were always bearing the brunt of problems. The people who died from COVID are the same people who died from flu every year disproportionately. We've got to focus on health equity. Lesson 9, we have to remember that economics and health are intertwined. In the 2020 election and since, health is pitted against economics. It was either you were pro-reopening or you were pro-fighting the virus. That's just silly. We know that if we don't fight the virus, people are going to be out sick, people are going to have long COVID, and you're going to be in a situation like we're in right now, where you go to a restaurant and it takes you twice as long to be served because they're running on half staff. We have to support health so that we can have a healthy economy. And then the final lesson is that lack of U.S. health resilience compromises our future pandemic responses. What do I mean by that? I mean the people who were most likely to die from COVID were obese, they were smokers, they had diabetes, they had high blood pressure. So we can say it's all about the virus, but really it was about the virus on top of a foundation of poor health in the United States. And if we don't focus on health resilience, then no matter what comes next, we're going to continue to be negatively and disproportionately impacted by it because we're a sick nation. 60 to 70% of our country is obese. What was interesting, and I do want to wrap up here and start to go into the Q&A, but the debate that I still have with people about who we should be directing our COVID messaging towards. And people will often say, naysayers will say, well, you should only focus on the high risk. Guess what? 60 to 70% of our country is obese. That is a high risk group. 50% of adults in the United States have high blood pressure. That is a high risk group. A third of our country, adults are pre-diabetic or diabetic. That is a high risk group. So when I'm focusing on everyone, I'm really doing it because the majority of our population fit into a high risk group in terms of COVID outcomes. If we were healthy and only 20% of the country was in the high risk group, we could be like Sweden. We could be like Switzerland. We could be like the Scandinavian countries who really tried to have this policy of protect the vulnerable and let everyone else do their own thing. But you can't do that when 80% of the country is in your high risk group. And so again, health resilience compromises our policies and our future responses. And with that, I will stop because I know we're going to go deeper into detail in the Q&A, and I want to, again, leave time for you all to ask questions. But those, I think, are some of the underlying issues that nobody's talking about because everybody wants to say it's Joe Biden's fault. No, it's Donald Trump's fault. And neither of those is true. We saw these same negative outcomes under both administrations and both presidents because we didn't change the underlying factors that actually caused us to have terrible outcomes in 2020 compared to many other developed nations. And with that, I'll stop and I'll turn it back over to Ray and Betty and to Sue to open up the Q&A.
Thanks, Dr. Adams. You set a good stage for this. My questions are like, can you tell us a bit about how you became aware you were going to be the U.S. Surgeon General? Did you get a phone call?
Oh my goodness, that is a funny question. So the United States Surgeon General is appointed by the President of the United States and then confirmed by the U.S. Senate. And that is another point I bring up in the book that makes public health challenging. And it's specifically why I said we need to make public health nonpartisan, but I didn't say that we need to make it non-political because it's impossible to make it non-political. Your health commissioners, your health directors at a county level, your Surgeon General, your CDC director, your FDA commissioner, they are all political appointments. And so one of the interesting things is it was right after the election, November of 2016, that I first met Donald Trump. I flew out to Trump Tower and met with him in all that chaos that was going on in New York City at the time. And, we had a great meeting, didn't know what was going to happen. 7 months passed, or 8 months actually. And it was July of of 2021, and I'm in Gatlinburg, Tennessee with my family, and my phone rings. And I look at it and it says, no caller ID. And I go, do I want to answer this? And so I pick up the phone and they go, is this Dr. Adams? I go, yes. They go, please hold for the Vice President of the United States. And I'm at a go-kart track in Gatlinburg, Tennessee, with my kids zooming around behind me and saying, come on, Dad, let's go, let's go. And Mike Pence gets on the phone and he says, Jerome? I go, yes, sir. He goes, how would you like to be Surgeon General of the United States? And I say, well, sir, if that's a job that you feel like I can do on behalf of this country, I would be honored. And so that is how I got informed that I would be Surgeon General of the United States at a go-kart track in Gatlinburg, Tennessee. But again, what's also interesting about that story is that it took 8 months from the first meeting. And it's really challenging for a lot of these political appointees to just sit around and wait for that long to hear back. And believe it or not, I was actually one of the fastest to be confirmed of any of the Trump administration appointees. And so that is a challenge we have in any administration. Congress will often stall nominations and hearings on people because it's political gamesmanship, and both parties do this. Joe Biden's folks, the Republicans in Congress put holds on them, and Donald Trump's folks, the Democrats, would put holds on them. And it hurts our country. It hurts our country because you need people in these key positions. You can't afford to have them vacant for long periods of time. But fortunately for me, I was one of the fastest confirmed, and I still am very honored to have had the opportunity to serve despite the bumps and bruises that I took along the way.
But you said that you did meet with Donald Trump before Mike Pence contacted you, right?
I
So
did.
you knew you were in the running. So how did that happen?
Well, what's also interesting is that and not a lot of people know this. I actually was being vetted by both Republican and Democratic administrations for a position had they won. So Hillary Clinton's folks reached out to me, and everybody thought Hillary Clinton was going to win. If Hillary Clinton had won, she would have had about 90% of the thousands of political appointments filled out on day one. Like they literally had a whole sheet because they just knew she was going to win. And again, this is hard to remember too, how much everyone thought Donald Trump was not going to win, literally right up until the news announcement that, hey, he won. Well, Donald Trump won, and Donald Trump didn't have any political experience at all. And you're coming out of the Obama administration, so there were very few Republicans just hanging out in DC. So it took a long time for him to fill out the government. And what ended up happening was a lot of people from Indiana ended up being tabbed for the last administration because Mike Pence had been governor of Indiana and also had a lot of relationships through his time in Congress. And so he could call up people and say, hey, I need someone for Department of Ag. That was Ann Hazlett. I need someone for CMS. That was Seema Verma. I need someone for Surgeon General of the United States. Jerome Adams, who was my former health commissioner in Indiana and did a great job. I can call that person up. So that was my connection, and it was the connection for a lot of people from Indiana who ended up in the prior administration. And I'm very proud of the work we did because, as I mentioned, they had a really difficult time. There were a lot of Republicans who were self-declared never Trumpers in 2016, if you remember. And so there were people who they would call who would say, no, I'm not coming to DC to work for that person, truly. And so the folks from Indiana, I really do believe this in many cases helped our country more than what they will ever be given credit for in terms of providing sound leadership. These were all people who'd served in government before under Mike Pence in the state of Indiana and were willing to step up because of Mike Pence. And I'll finish by saying this. One of my concerns about health in general and also government is that we've created a very an environment that is not at all inviting for people to want to serve. Before we brought on everyone else, I was having a conversation with Ray and with Sue and with Betty about the need for young people to get involved in government and to run for office. Why would anyone ever want to do that in a world where you're going to get death threats, where you're going to get ripped apart by the media, where they're going to dig into every little detail that you've ever posted on social media and use it to attack your character? I really worry about a world where good people no longer want to step up and serve our government. And I feel like, particularly in public health, we're in that place because public health got beat up pretty badly. I know a lot of folks who did get, I got death threats delivered to my mailbox, hand delivered to my mailbox. I know because there was no stamp. It was literally a letter in my mailbox that had that was a death threat. So someone came to my house and put it in my mailbox. And if we don't find a way to support public servants, even when we disagree with them, to at least be respectful towards them, we are going to be in a very bad position moving forward. But again, to answer your question, my involvement largely came through my time as state health commissioner and my relationship with Mike Pence, and I'm grateful to him for giving me that opportunity.
That's great. Thank you. Thanks. Well, when you started the position, you stated your goals were addressing mental health challenges and the opioid epidemic. Then in 2019, the focus shifted to COVID-19. Do you remember a time or a specific meeting or where you realized that COVID-19 was going to change everything for everybody? How'd your job change?
Oh my gosh, what a wonderful question. And I want to back up a bit because one of the challenges, and I know I'm on the call with many folks who've had leadership positions that are as high level as mine, who've supervised as many people or more people than I've supervised, and so you all will understand this. You go into these high profile leadership roles with your plan of what you want to accomplish. And then reality hits and you start having to deal with putting out fires and you start having to deal with crises that pop up. And for me, when I came in actually 2017, I had planned on focusing on the opioid epidemic because a person at that time was dying every 11 minutes from an opioid overdose. And it was the crisis of the time. Well, guess what? 1 week into office was when the 3 Category 5 hurricanes hit in a row. First time in history. You all remember that? I believe it was Maria, Harvey, and Irma. And that ended up being our biggest deployment of public health service officers in U.S. history. Public health service is 200 years old. That was our biggest deployment in history, was responding to those 3 Category 5 hurricanes. I didn't plan on being a hurricane expert. I didn't plan on spending the first several months of my term in the southern United States and in Puerto Rico and the U.S. Virgin Islands, but that's what ended up happening. So you're constantly having to adapt to what's going on while also trying to keep your own priorities moving forward. So 2019, what is interesting about 2019 is that 2019 was the year of measles. And this is something else people forget. They act like vaccine hesitancy is new or started with COVID. We almost lost our measles eradication status as a country in 2020 because of outbreaks that occurred in New York, in Rockford, New York, in the state of Washington, in California, and then American Samoa. 83 children died of measles in American Samoa in 2019 and early 2021, before we were even talking about COVID, or early 2019 and early 2020. And so I'd spent most of 2020, or 2019, particularly the end of it, visiting places where they were having measles outbreaks and trying to encourage an increase in measles vaccinations. An irony, where are we now in 2024? Measles outbreaks all over again due to low vaccination status. So you asked the question, when did I know my life was going to change? I was supposed to go on a trip to the American Samoa in January of 2020. We'd been planning this trip for literally 6 months because that's how long the measles outbreak had been going on. and I was supposed to go there in early January of 2020. And I got a call that said, we have to pull down your trip because this virus that's brewing in China looks like it's going to be a bigger deal than what maybe we thought it was. So that's when my life started changing, when I started having to change my schedule because of the virus. Now, that's not when the US changed. What's ironic is the reason why I love this question that you asked me is that when it changed for the rest of the US was when they canceled March Madness. That's when the country said, oh my gosh, they're canceling March Madness? That's a big deal. And so we're going through this right now. And it didn't matter what I said or what Tony Fauci said in February or in early March. It was when they canceled March Madness that everybody said, oh my gosh, this is serious. We better start paying attention. And the lesson there is that it's really hard to get people's attention about a public health issue unless it's directly impacting their lives. And even though there were thousands of people who were sick, hospitalized, dying in China, in Italy, and then in Seattle, Washington, it didn't matter to the rest of the country until it impacted their lives. And we have to remember that. That's one of the lessons from the book, is that we can try to scare people all we want with real data, but you have to make it real for them and understand what's going on in their lives. And in many cases, even when it hit New York and New York was imploding, and it truly was imploding, people in Boise, Idaho were saying, I don't know a single person who's gotten COVID. And so they thought we were full of what when we're saying, okay, we've got to shut down schools for COVID because the country's in trouble, when they literally don't know a single person who's been hospitalized with COVID at that point. That's one of the challenges we had in the US, is the virus played out very differently and at different times in different parts of the nation. And we were trying to give a one-size-fits-all message from Washington, D.C. That really fell flat on a lot of the country.
Thank you. Well, what about, the COVID's revealed a lot of things, but it doesn't, the pandemic, doesn't respect borders, and there's global connectivity with healthcare systems. So what about global cooperation? What progress is being made in the area of any global cooperation?
Not enough.
Is WHO the best organization to coordinate this, or
what? Oh, you're going to get me in trouble here. So I'm going to Switzerland next week to have a conversation about this very topic, about global health security. And what is interesting is, if you want to go back and look at and talk about Donald Trump and global health, I'll give you two sides of the same coin. Donald Trump lashed out at the WHO and threatened to pull the US out of the WHO. And many people criticized him for that. Number one, I will say that we need international cooperation, particularly in a world that is becoming much smaller. There's nowhere in the world you can't get your Amazon package from in 24 hours. So there's nowhere in the world you can't get a virus from in 24 hours. We absolutely need international cooperation. That said, I understand why Donald Trump was frustrated. China withheld information from us for literally about 6 weeks. And when I look back on 2020, and I ask myself, what would have changed our outcomes? As I mentioned earlier, as I started off this call by saying, having a different person in the White House didn't change our COVID outcomes year over year. A lot of the things that people think would have made a difference didn't make a difference. What would have made a difference would have been had we had the information from China about about person-to-person spread and about asymptomatic spread. That would have changed our recommendations and the way we were thinking about this virus. And I really do believe it would have saved lives. Well, the WHO to this day still has not held China's feet to the fire, still has not held China to account for withholding that information. And Donald Trump was very frustrated about that. and said, well, why are we sending all this money to the WHO, who refuses to hold China accountable for withholding information? And then that's hurting our country and our economy. So I think moving forward, we need to support international cooperation, but we also need to figure out how we hold these international institutions accountable and these international partners accountable when they fail us. The WHO absolutely did fail the world in 2020 by not pushing China harder to let the CDC and other international folks in early on, and by not sharing information. But the answer isn't to just pull out completely, because then we don't have access to information in that scenario either.
On the home front, how should the U.S. enhance its pandemic preparedness for the future? What should be done to strengthen our response, or what are your thoughts about the future in the United States?
Well, I talked a little bit about that in the beginning in my 10 lessons. I really do believe we need to strengthen our baseline health, because we're going to get our butt kicked by anything that comes our way, whether it's a hurricane, or whether it's the opioid epidemic, or whether it's a new virus, or whether it's antibiotic resistant microbes. If we continue to have again 60 to 70% adult obesity rates, 50% hypertension rates, and so on and so forth. So we really need to pay attention to baseline health and resiliency by creating healthier communities where the healthy choice is the easy choice. And that's a lot of what I'm working on at Purdue. Creating communities where it's safe and easy for people to go out and exercise. Creating communities where people can afford and have access to nutritious foods and don't feel like their only choice to eat is to go to McDonald's and get a 99-cent cheeseburger, or go to the corner convenience store. That is really, I think, going to be key moving forward. I also really am concerned about our flagging vaccine confidence in this country. We have saved millions of lives, tens of millions of lives over the last 50 years because of vaccines. And in many cases, we're victims of our own success, because many people alive don't remember what it's like to live in a world without these vaccines. Many people alive and making decisions don't know what it's like to have polio, or to have a loved one with polio and an iron lung, or to see someone actually get measles. And so I think we really do have to lean into vaccine hesitancy as a matter of national security, quite frankly, and in national health. And I also want to say that I don't think the answer to our problems is defunding the CDC or defunding public health. Yes, you can be frustrated with public health. My whole book is about, looking at what we did wrong and trying to improve things, but you don't make it better by defunding public health institutions. I think there's a real danger here with the backlash against public health, and with the idea that we're going to give public health even fewer resources for the next go round. I said I didn't go into depth earlier on, and I won't go too much into depth here. But I do think one of the challenges is the CDC wasn't meant to be a fast reacting organization. The CDC is more of a, let's study the issue for several years, and let's write a paper on it, and let's publish the paper in 6 months after we get our data, and then let's respond to it. We do need a CDC that is more responsive to quickly changing events on the ground. And we need to create some sort of separation between the CDC and actual policies, because there's a difference between saying this is what we should do from a scientific standpoint, and then saying this is what we are going to do as a country. And I alluded to this earlier. A CDC should be in a position to always say, here's what the science tells us we should be doing right now. But that may not always jive with keeping schools open, or preserving the economy. And those things are important. But the CDC shouldn't be the one who's on the hook for making or explaining those decisions to the public, because then people lose confidence in the CDC when they feel like they're weighing in on issues that go beyond the science. They should be saying, here's what the science says, and then handing it off to someone else to make the policy decision and explain the policy decision to the American people. And so I talk about that in more detail in my book, but I feel they were in a horrible position because, like I said, that mom in Boise, Idaho is saying, why are you telling my kid that they can't go to school? Or why are you telling my kid who has speech and language issues that they have to wear a mask when we don't have any COVID cases confirmed in our community at all? That's not something that I think really is fair to the CDC. And so we need a different agency and entity to kind of help make some of those tough decisions and balance the trade-offs and explain them to the public.
Thanks. I guess this is going to be my last question, but the stresses caused by the pandemic domestically had a significant impact on other disease treatments. And how has the pandemic impacted screening and treatment for cancer and other chronic diseases? And can you share a little bit about the story of your wife and how the pandemic has impacted her diagnosis and treatment?
Well, I'll share stories about more than my wife. But for those of you who don't know, my wife has metastatic melanoma, and she had a delayed diagnosis of her latest recurrence because it was 2020, and she couldn't get into the doctor's office. And this is a great example of what I just talked about. The CDC should say, this is what you should be doing to protect yourself from COVID. But the CDC isn't necessarily in a position to say, but this is the harm that can come from this if you delay or deny people medical care in another place. That's a policy trade-off that we have to make. But again, it's a terrible position to put the CDC in to say to be saying, well, the science says that you shouldn't go and get your cancer, you shouldn't go for your breast cancer screening or your melanoma screening or your colonoscopy. They lost a lot of credibility there, and there were people who were harmed. So that's my wife. My brother has substance use disorder. And we know that many people with substance use disorder were disconnected from services because they closed down medication-assisted treatment in many cases. They closed down AA meetings. They closed down really important opportunities for people who have mental health and substance use disorders to be connected with care and the services that they needed. So you saved them from COVID, but you may have caused them to die from an opioid overdose. Again, really tough trade-offs that had to be made. My mother had a stroke in early 2020, and she was not able to get the rehab that she needed because, again, the rehab facilities were closed down. So in a very real sense, my own personal family experienced harm from COVID mitigation measures. Now, does that mean that I'm against COVID mitigation? Absolutely not, because for the same reasons, my wife, my mother, and my brother were all also high risk for negative outcomes from COVID. But it is to say that in the future, we need to be more cognizant of the downsides of people missing school. Like I had three school-age kids during the pandemic. And, one of them did well with homeschool. One of them did really poorly with homeschool. So I experienced all these challenges in real life. And so what we need to do, however, moving forward is instead of pointing fingers and saying, these Joe Biden and these horrible pandemic measures ruined my kid, we need to say, okay, this happened. It was a once in a century pandemic. People did the best they could at the time. We need to do better moving forward. We also need to recognize these deficits that we now have in terms of our health measures, and we need to work hard to correct them. I hear way too many people saying, Tony Fauci needs to go to jail because he kept my kids out of school, and not enough people saying, okay, what kind of resources do these kids who have learning loss need in order to catch up? It's more of a focus on looking backwards and pointing fingers and blaming than what it is on actually being honest about the problem and then providing resources to help correct the problem moving forward. There's a saying that my father often shares. There's a reason why the rear view mirror is tiny and the front windshield is big, because you're supposed to be looking forward. But we're spending a whole lot of time focused on that rear view mirror and ignoring the road in front of us and all the opportunities, but also all the dangers that lie in front of us if we aren't paying attention to the road. And so I really do feel like there are a lot of health deficits and educational deficits that exist out there. And I feel like we have the capacity to be able to help people more than most any other country if we could focus on that front windshield and not so much on that rear view mirror.
Thank you for sharing your personal perspectives and personal stories. But I think now it's time to let our audience ask questions, because I'm sure several have them. So
Well, I hope you all aren't too mad at me for I'm very open and honest about things, for better or for worse.
I mean, I really, really appreciate it. But I think it's time, Ray, take over and people ask questions.
Okay, Sue, thank you. Jerome, thank you very much for those insights that you provided for us. We have several questions from folks in the audience here. I know Sue has a few more questions she wants to ask, so if we run out of questions from the audience, which I don't think we will at this point, but we can go back to a couple of Sue's questions. But at any rate, Audrey B, are you out there, Audrey?
Audra.
Audrey, yes.
Audra. Yes, hello. Hi. So I'm asking this question as a person who has long COVID. I also have a master's in public health from here at IU. Yeah, so I am a public health geek. But I found even before I got COVID, I did all the vaccines. I got COVID in May last year. So I'm at about 10 months of not having a life. I'm not dead, but I'm not living. So we focus a lot on mortality data. You used mortality data for the measles in Samoa. But we knew that viruses and illnesses cause complications, hearing loss with measles and other things. There are a lot of reasons why we get our children vaccinated that isn't just about avoiding, avoiding death. I found that we've spent too much time focusing on mortality and not enough on the morbidity, as we say in public health, the illness and the lost quality of life. I have neurologic issues. I had to find my own healthcare providers. I've gone to Chicago, to Northwestern. There's a neuroinfectious disease specialist there who was working on HIV impacts on, neurologic issues prior to COVID and is now focused on COVID. But if you look at what's out there in the press, it's that, oh, we didn't know COVID did this. Well, we knew viruses do these things. How are we going to look forward, not in the rearview mirror, not blame? I'm hopeful that I'm going to get better. But how are we going to ensure that the morbidity is being addressed, that the long-term complications are being addressed? We had this with various populations. It's just they weren't, the original numbers getting the viruses and the illnesses weren't big enough to give this cadre. I mean, we've got millions of people, and I know many just through my personal life who have dizziness, lung problems, brain fog, etc. Most of us can't work. I can't drive. I had to retire from my drug development career because of this. So how are we going to ensure, what are your thoughts based on what you saw, that we're taking, a longer term view and the bigger picture of the full morbidity of these things?
That is a fantastic question. First of all, really sorry to hear that you're dealing with long COVID. I know that has significantly impacted a large number of lives, literally millions of people. And one of our big failures, and I actually talk about this in the book, because, and I'm so glad you brought it up, is how much we focus on mortality over morbidity. And it's, you know, it's tough. It's tough because mortality is easy to measure.
Yeah,
You know,
when
and-
it's happened. And
Exactly. And that's a problem we've long had in public health. We have it with maternal mortality. You know, it's easy to say X number of moms died while giving childbirth. It's a lot harder to quantitate the morbidity from moms who lived, but who were hospitalized or who had other complications. And so one of the answers to your question, and it's not an excuse, but it's an answer, is that mortality is easier to measure than morbidity. But another problem is that, or reason, is that mortality is more shocking than morbidity on its face. You know, let's be frank, you're showing a dead body versus you're showing someone who, looking at you, no one would know that you had long COVID looking at you. And so, it's very hard to make a compelling visual case for morbidity over mortality. But that said, here's what I think we need to do, and I'm so glad you brought this up. I put out a report when I was Surgeon General that is unlike any other report written by any other Surgeon General, called Community Health and Economic Prosperity. And the reason why it's different than any other report by any other Surgeon General is because it wasn't written for a health audience. It was actually written for a business audience. It was making the case that the U.S. Is spending 3 times as much on healthcare as the OECD average, and it's continuing to get terrible results. And it's impacting our workforce. It's impacting our economic competitiveness. I'm literally trying to put a face in a value on the morbidity in addition to the mortality out there. The truth is that from an insurance standpoint, and healthcare is the number 2 expense for most businesses in the United States, because 50% of insurance in the United States is provided by employers. When someone dies, that actually saves insurers money. When someone lives with a chronic illness, that costs insurers money. And so
just to say on that, I don't look sick, but in the last year, and I have none of the standard comorbidities. I've been to the ER twice. I've been hospitalized, and I reached my maximum out of pocket for 2023. So, there are ways to make this, we don't typically show the dead bodies. There are ways to make this kind of thing more shocking because the order of magnitude is much higher than the mortality. And honestly, we don't want, I think that it's disproportionately affecting women. I think a lot of this is also impacting the people available for employment, the employment rate, and that there's just a ton of people who are not able to work because of this. Anyway, I didn't mean to interrupt you, but
no. I love it. I love it. I want to bring you on the road with me because that's literally what I say in my report. I talk about healthcare expenses direct, and I talk about the indirect cost of absenteeism, missing work, of presenteeism. I mean, when you talk about moms, I had severe asthma most of my life when I was growing up. My mom was my primary caregiver. So she either missed work, or when she was at work, she's on the phone talking to my doctors, trying to, so from a work, and then there's people who just literally can't go to work and they're on disability, because of chronic illnesses. So I try to quantitate all that in my report to make the case to businesses that we need to invest in prevention and health and wellness, and in making sure we're providing adequate healthcare coverage for everybody out there, and not just people who've got good jobs and good insurance. Exactly. And so couldn't agree with you more. And those are the things that we're trying to really lean into. And again, we have to understand the problem before we can deal with it. There are real reasons why people focus on mortality. But that said, I couldn't agree with you more. We need to understand that the societal impact of morbidity is far greater than the societal impact of mortality in many cases. And so we need to pay attention to that.
Yep.
And we need more research on long COVID. Dr. Francis Collins was out here. He's a former NIH director, for those of you who don't know. He was out here about a month ago, and we talked a lot about more funding for long COVID. But I'll finish by saying that that's one of the challenges of this virus. Tony Fauci has been doing this for 60 years. 60 years, and I will never forget, Tony said to me one day, he said, in all of my years of studying virology, I have never seen a virus, never encountered a virus that has this degree of variability in how it impacts people. Some people get it, and it really is a cold for them. Some people get it, and they don't even know they had it unless they test positive. And other people get it, and they're on a ventilator 2 days later, and still other people get it, and they feel fine at first or a little sick at first, and then they get long COVID, and they're debilitated for years. And so Tony said this, and I'm like, hearing him say this, it really stuck with me that it's hard it was hard for us to wrap our heads around the idea that this virus really would play out this differently in large numbers of people. And then it's hard to message when you've got a virus that plays out this differently, because my 96-year-old granddad was one of the first, or my 96-year-old grandfather-in-law, my wife's grandfather, was one of the first people in Indiana to get COVID. He got COVID and he was out golfing 3 days later. I mean, and so when people see that, they go, you all are full of you-know-what when you're telling us we should be scared of COVID. But then, I've also got people in my family who've been deathly ill in the hospital, because I have a cousin who's younger than me who now has chronic heart problems because she got viral myocarditis from COVID. And so one of the youngest people in my family and healthiest people is now disabled probably for the rest of her life. And one of the oldest and most vulnerable people in my family was out playing golf immediately afterwards. That's one of the challenges of this virus, is it's so hard. It's still hard for people to wrap their heads around the variability and to communicate it.
Yeah.
All right. Thank you, Audra.
Thanks.
Thank you, Jerome. Trevor Williams is up next, and then Deb Myers, and then Mel Miller, and then we'll go to Claire Collins. So we got a queue of questions here for you.
All right, I'll try to be quicker in my answers so we can get to all of them.
Take your time.
Okay, Trevor, you're up.
Dr. Adams, thank you so much for taking your time to speak with us today. I know for myself, I'm an MBA student right now, and it feels like every assignment I do, I mention COVID in some way. So it's kind of really cool just to have you, the person who was pretty much the face of COVID for a while, to be here to talk with us. My question has to do with a lot of millennials like myself, what we're thinking about these days, which is AI.
Mm-hmm.
And AI over the last, I'll say year and a half, has really changed the way we are able to look at everything. I think about how during COVID, it seems like the conspiracy theories move faster than the actual truth. Mm-hmm. And now in the time of AI, it seems like it moves even faster. I can't watch a YouTube video without a video of Donald Trump telling me I need to get this $6,400 subsidy that somehow exists out there. So I just kind of wonder, in the thought of public health, how do we combat AI misinformation, and what could we do with AI to probably try to mitigate what is going on with the misinformation that we're dealing with today? And thank you so much for being here.
Well, thank you so much for the question and for you being here. And you're right. I imagine many of you all have read one of my favorite books called Outliers. Outliers by Malcolm Gladwell. And if you haven't, it is a fantastic book to read. It really, and it's timeless in the stories that he tells. But he talks about how folks like Bill Gates and folks like Wayne Gretzky, who we think of as these great individuals, really were folks who were benefits of the time in which they were born and the time in which they grew up. One of the points is that timing matters. And he also highlights that there are seismic shifts in the way society functions that often we have no control over. Whether it's world wars, and World War I saw a massive increase in blood transfusion technology and blood banking. World War II was the first Operation Warp Speed, where they massively scaled up penicillin. And after that, it changed the way that we looked at infections and antibiotics. In COVID, it's once in a century pandemic. It was one of these things that we're going to be talking about for the next 100 years in terms of how it impacted our planet and impacted everything. It impacted school, it impacted businesses, it impacted, the transport of goods. We didn't have meat on the shelves. It impacted toilet paper. It literally impacted every part of our lives. And so, but one of the things I try to highlight in my book is that there's a lot of bad, but there's also a lot of good that came out of COVID. So when you talk about AI, I think more broadly about digital health. One example from the pandemic is that telehealth increased by 7,000% during the pandemic. This was something we've been talking about for 20 years, telehealth. But the pandemic really pushed us off, the fence post, and forced us to have to figure out, how do we make this work from a regulatory point of view, from a technical point of view? And we're never going to go back. We're never going to change again. But I do think that we really need to be cognizant about the health equity implications of digital technologies, including AI. We need to be careful about the bias that can be baked in, because bias in equals exponential bias out. The old saying used to be garbage in equals garbage out. Well, now it's garbage in equals exponential garbage out with quantum computing and with AI. One of the points I made in the very beginning was we have to figure out how to combat misinformation and disinformation. Well, now with AI, we can literally do a deep fake video and you wouldn't know whether this was the real Jerome Adams talking to you right now or an AI generated version of Jerome Adams with my exact same voice and my exact same cadence, and speaking to you right now. So it's a real challenge, and the way we have to face challenges is head on. We have to face them with awareness, and we've got to make sure we've got all the right people in the room. I talk about the need to make sure we've got diversity in the room when we're contemplating regulations and rules, so that we understand our blind spots. What's one of those blind spots? If you look at our cell phone, how many apps do you all have on your phone? How many free apps do you have on your phone? Let me tell you, none of these apps are free. If you're not paying for something, what's the saying? If you're not paying for it, then usually you're the product. They're taking your data and selling it and leveraging it in order to make money, which is why they're giving you the app for free. And those 3 pages that you didn't read when it accepts the app, when you just clicked accept, gave it access. You gave access to your camera, to your speaker, to everything on that, to your data, to your emails on the phone, so that they can sell it. Well, one of the things we have to ask is, okay, so if someone else is making money off of my data, what about me? When you think about Henrietta Lacks, for those of you who aren't aware, is someone whose cells have been used in about 60 to 70% of the drug products on the market today. They took her cells without her permission and used them, and never told her family, never gave her family any money from it. Well, this is happening in the digital space right now. They're taking all of our data and they're using it to create products that make trillions of dollars for people. Well, should we have some of that data? And then what happens when that data is used for nefarious purposes? What happens when it gets out there and then all of a sudden the insurance companies say, well, it looks like you're going to be at higher risk for cancer down the road, so we're going to have to charge you a higher rate, or we're not going to give you insurance coverage at all. That's a very real possibility with these digital health technologies. Final point that I bring up is again, a lot of bias baked into even devices. So the pulse oximeter, speaking of the pandemic, the way that we measured your blood oxygen levels was designed and tested mostly on white males. Well, it's measuring the transmission of light through your skin. Lighter skin is going to transmit light differently than darker skin. They didn't know this for decades. So for decades, we've been misdiagnosing people with darker skin color as being fine when really they were very sick. So this impacted the pandemic. This impacted people like me growing up with asthma. Many times, I went into the hospital and they told my mother I was fine when the truth is I may not have been fine. So there's a lot of opportunity for bias to be baked into product development and the software design, and into the ways we communicate with our community, and into who's impacted negatively and positively by digital health technologies, including AI. And we need to be very cognizant of it from the start, proactive versus reactive. And we need to make sure we have diverse representation at the table so that folks can see their blind spots when they're dealing with these issues.
Hey, thanks, Jerome. Trevor?
That was a wonderful question. And I love talking about it. That could be a whole nother, I literally have an hour lecture on digital health equity. I'm writing an article on it right now. And so, Trevor, fantastic question. And I really hope people are thinking about this and paying attention to it, because there's potential for tremendous good to come out of it. There's also potential for tremendous harm to come out of it.
Thank you so much,
Well,
Dr. Adams.
interestingly, Trevor, you had something to say?
Just thank you for your response.
Okay, thank you. Our distinguished speaker program in May, by the way, is going to be on AI. So this is kind of a timely discussion here. Okay, I think Deb Myers is up next. Deb.
Thank you very much, Dr. Adams, for your presentation, and I appreciate you sharing your vulnerability with us. Speaking of public health and the likelihood that in this changing environment, pandemics will become more prevalent than once a century. What, in your opinion, will help bring our population along to understand the necessity for the underpinning of public health and help us commit resources and investments in our public health system, both locally and nationally?
That's a wonderful question, Dr. Myers, and I want to underscore something you said. It was 100 years between pandemics. It won't be 100 years before our next pandemic. It absolutely won't. When you look at climate change, when you look at, like I said, the fact that there's nowhere in the world you can't get to in 24 hours. When you look at human encroachment in animal spaces, and the fact that we're going to see more zoologic diseases, not less. I mean, the big news literally today is a bird flu found in cows. And so that continues to be a concern. So we're going to see more and not less. And what can we do? Again, I think we need to make the economic case for health, because in many cases we defined health as a personal issue. And if you're in poor health, that's a you problem. And in many cases, we blamed it on individuals. What I did in my report that I mentioned earlier is to frame it as a societal problem. It hurts us all when an individual has poor health, and to talk about societal solutions, such as creating more public opportunities for health and societal opportunities for health. We need to make it easier for people to get information about vaccines so that we can combat vaccine and misinformation. We need to make vaccines more available. In many cases, people aren't, we blame people for not getting vaccinated and call them vaccine hesitant or anti-vax, when the truth is they may be working 3 jobs and can't get to the CVS between the hours of 9 and 4 when they're doing the vaccinations. There's lots of things that we can do to create more opportunities for health, but we need to make the investments. And the way we make the investments is by making the economic case. And I'll give you a real example of this. Many of you all are aware, Indiana increased its public health funding by 1,500% in the legislative session before last. And this is very unique amongst all states, but particularly amongst red states or conservative states where public health funding is being cut. We got a 1,500% increase, and this is receiving national attention in case you all didn't know. Politico article, Time Magazine covered it. They're covering the fact that we increased our public health funding in this state. Now, I know the governor. I know the people who pushed this through, and they will tell you that they didn't push this through by making the health case or the moral case for health. They pushed it through by making the economic case, by saying, hey, if we want a healthy workforce, if we want businesses to move to our state, that's not going to happen if we're ranked 47th or 42nd in public health. That's not going to happen if we're ranked in the bottom of infant and maternal mortality. That's not a state that young people, young families want to move to. And so when we make that economic case for health, and when we get businesses behind us, then all of a sudden, the legislature and leaders stop looking at it as a you problem or an individual problem and start saying, okay, it benefits us all to invest in health, including pandemic preparedness moving forward.
All right, thank you. Okay, so we have 3 questions left, and I think we have enough time to get them all in here.
Rapid fire, all right.
We got Mel Miller, then Claire Collins, and Dennis Kelly. So Mel, if you want to go up.
Okay, thank you. Only by the grace of God am I here to ask this question, but I often wonder whether they keep this kind of data, because I was scheduled for my second open heart surgery at Mayo Clinic early in 2021. And I had to keep putting it off because the hospital was full and they couldn't take anymore. At first, I took it as that's a good sign because there must be other people that are needed it more than I do. But by the time I got in December, and like I said, I was very fortunate and thankful to get through. But I get back home and my cardiologist says, I didn't think you were going to make it. But like in the electric utility business, they have to build their plants to peak load and not average load. Is there any statistic to show how many other people died, not from COVID, but from lack of ability to be treated in the hospitals because all the beds were full? That just amazed me during that COVID, that how many hospitals were completely full and over capacity. So there had to be some deaths that weren't COVID, but they are definitely COVID related.
Well, no, there absolutely are. We lost lives, no doubt, because of care delayed or denied during the pandemic. And as I say in the book, we've got to figure out in the future how to walk and chew gum better at the same time. But one of the things that I mentioned, my very last point, is that we need to focus on health resilience. That is both an individual, health resilience of individuals, because one of the problems in our country is that so dang many people need a heart surgery. And it's not to say anything about you, but it's to say a lot of folks out there who need this surgery in the United States wouldn't have needed it if they'd grown up in Europe, because they would have had healthier food choices. They would have had more opportunities to exercise. They would have had more preventative screening, and they wouldn't have gotten to the point where they needed this in the first place. That's number one. But the point that you bring up, I think, is a good one. There's also health resilience in the system. And our system failed in 2020 in many ways. It failed because we stopped providing needed care to a lot of folks, but it also failed because we didn't understand how to leverage the capacity that we had. For every hospital that was overflowing, there were 3 or 4 hospitals, maybe 10 hospitals that were completely empty. This is a true story. It blew my mind. When New York was imploding, and when there were people literally lined up in hallways and dressed in trash bags because they didn't have PPE in New York City, I was at the same time getting phone calls from nurses in upstate New York who were calling us to complain that they were being furloughed because their hospital was closed during COVID. So part of the problem is that we don't have a good system in place that allows us to say, okay, you've got too many, you don't have enough, let's shift the load a little bit. It wasn't that the capacity wasn't there, it was that we didn't have a system that knew how to leverage that capacity. But truly, for every hospital that was overflowing, there was a hospital that was empty or low capacity that wasn't being utilized or leveraged. And we need to figure out how to do a better job of that in the future. And again, that's something I talk about in my book. But if we can turn the spigot down, so to speak, by improving individual health, and also increase the capacity by figuring out how to better leverage the slack in the system that does exist out there, then I think we'll be better prepared for the next pandemic. If we do neither, then we're going to be in the same situation all over again. And finally, I want to say thank goodness you made it, because a lot of people didn't. And I'm so glad that you are here to ask this question. The true story is, again, I was worried my wife wasn't going to be here. I was worried my brother was going to overdose because he wasn't getting the care he was going to need. My mother actually did have a rapid decline and is now in a nursing home with dementia. And I don't know whether that would have been staved off a little bit had she been able to get rehab for her stroke or not. But again, I'll be left wondering that the rest of my life. So really glad to see you here, and hopefully we can prevent harm from coming to other people in the future.
All right. Thanks, Jerome. And thank you, Mel, for that question. Claire, you're up next. And then Dennis will be our final questioner for the evening. So, Claire,
Okay.
Go ahead.
Yeah, thank you. I'm a retired respiratory therapist, and fortunately for me, I got out of the business. I retired before the pandemic started. But yeah, so I was interested in everything that was going on and watching TV and seeing stuff on the internet. And there was such a shortage of PPE and ventilators, and there were a couple of engineering students in Washington State who came up with an invention of a, quickly put together cheap ventilator.
Mm-hmm.
And they showed that on TV close up. And I saw that and I thought, oh, that was state of the art 40 years ago. But this, this disease is a lung shredder. And I knew that it would need, like the Servo I or the McKay ventilators. And the McKay, I guess the Siemens from Sweden gave the patent to a company in Ohio, and the McKays are manufactured in Ohio. And then there was a factory in Kokomo, Indiana. I think it was a car factory, and they turned it into a ventilator factory, and they were making the same kind of ventilator that those guys in Washington State came up with. And also I remember that we were out of masks because we had outsourced all the mask production to other countries to save pennies per mask. And there was a shipment from outside the country, and Jared Kushner commandeered it. And I think he was going to hold on to the masks for the highest bidder. He's always on the grift. But anyway, I was wondering, have we learned our lesson regarding the manufacture of masks and ventilators in the U.S. instead of importing them from outside the country? And are we still producing the necessary equipment?
Well, so you hit on a couple of things that I want to highlight really quickly, and some of them came up in the last question. One of the important things that I think came out of the pandemic was, and it really in the very early parts of the pandemic, it was amazing how people rallied. Remember, people were making masks for one another. There were companies that converted to making hand sanitizer. And as you mentioned, people were really, really leaning into American innovation and ingenuity to try to respond to a global crisis. Then what changed, and we don't have time to go into this, but you can literally follow this. What changed is the more the politicians started to talk about the pandemic and the more it became an election issue, the more divided the country became. So the country actually was together originally and said, hey, the virus is the enemy. Then it became, oh, Joe Biden is the enemy. No, Donald Trump is the enemy. No, these people who want to close us down are the enemy. No, these people who want to force us open are the enemy. It became an electoral issue. But I do think we should remember again some of the good innovation that came out of the pandemic and some of the camaraderie, the patriotism that really was in the very beginning. That's one point I want to make. Another point I want to reiterate is, again, if you look, and this was a challenge for us, if you look at the national data and the national dashboards, we literally never had a shortage of ventilators. We never had a true shortage of PPE. What we had was a mismatch. For every hospital that was out of PPE, there was an outpatient surgery center or a dentist office or a rural hospital that was completely shut down that had a full warehouse full, had closets full of the stuff. It was here. It was just incredibly mismatched. And so one of the challenges we had is we're looking at national data and we're going out there, believing that we got plenty when the fact is New York has none. New Orleans has none. Detroit has none. And so we do need to have a national dashboard where we can have visibility into what is where and be able to redistribute it more quickly. And so that was the point I made. All the ventilators that they came up with, that they bought and they produced, we didn't use a single one of those during the pandemic. We had enough ventilators. And as a matter of fact, we found out scientifically that it was actually harming people because we were putting them on ventilators too early. You remember that, other respiratory therapist. And so, again, a lot of lessons learned about supply and demand. But I'll answer your one question, and I hate to do this, but I'll end on a bad note. No, we haven't learned our lesson about supply chains. We haven't created, again, that national dashboard that will allow us to more quickly redeploy resources. And we also, as soon as the pandemic was declared over by the powers that be, we went back to buying from the cheapest bidder. And many of those companies that were producing these products in the United States that literally stood up new US-based companies to make gowns and to make masks and to make gloves. The hospital systems and the government went back to, okay, we're just going to buy it from the cheapest bidder. And we literally went right back to the way we were doing things before. So that's one thing that I highlight in my book where we haven't learned our lesson, and we're going to get burned again in the future if we don't continue to make the supply chain an issue that our leaders think about and talk about in terms of pandemic preparedness.
Thank you.
Yeah, so I apologize. I told you I'm sometimes a little too honest. I'm not going to lie to you about it. We literally went right back to doing the same old things, and Sanity's doing the same thing and expecting a different result. We went back to doing the same thing, and we're just hoping that we don't have another pandemic anytime soon. All right, I think we got one more question.
Venice?
Mine's just a short question. Is there still such a thing as asymptomatic spread of COVID?
Absolutely. Absolutely. As a matter of fact, what you're seeing is more and more asymptomatic spread. And it's important to remember that when we talk about asymptomatic, that can be people who are pre-symptomatic, meaning that they have the virus, they're going to get sick 3 days from now, but they're infectious right now. It can be people who are post-symptomatic, meaning I had the sniffles and now I feel better, but I'm still able to spread the virus. And there's a significant number of people who get COVID who are infectious, but literally don't even know they have the symptoms. And the belief is that that's actually occurring more so, all three of those things, because we have such a high vaccination rate and because so many people have been previously exposed. So because so many people have antibodies one way or the other, it is causing more people to actually be asymptomatic at various times, but still be able to spread the virus. And that is the concern that we continue to have. We are in a better place, and this is a good note to close on. We're absolutely in a better place now than what we were in 2020. People are more protected than what they were back then, and we have more tools than what we've ever had before. But not everyone has access to the tools. Not everyone has faith in the tools. Not everyone is utilizing the tools to protect themselves. And so that's really one of the pleas I finish with in my book also, is understand your own risk, understand the risk that you're taking when you go out. And so I don't wear a mask when I'm in a restaurant anymore, because I'm going to take off my mask to eat anyway. The benefit is very low. But I do wear a mask when I'm flying on a plane, because I'm going to be around tens of thousands of people in the next week when I go on spring break with my kids, who are coming from all over the world. And so I'm assessing my risk. I'm assessing my risk around me, and I'm going to utilize the tools that I have available. I'm vaccinated. My kids are vaccinated, meaning up to date on the vaccines. I'm going to wear a mask when I'm traveling. I'm going to take risk when I feel like the benefit of spending time with my family outweighs that risk. And if we get sick, then we're going to test. And if we test positive, we're going to take Paxlovid. I'm in a position to utilize those tools because I have access to them, because I have confidence in them. And unfortunately, far too many people out there aren't in a position to do that for any number of reasons. And so we've got to make sure we put everyone in the position to make healthy choices. That's what health equity is about. It's not about forcing anyone to do anything, but it's about making sure everyone has an opportunity to make good and healthy choices. And if we focus on that, then I think we'll do better in terms of COVID, and we'll do better in terms of the next pandemic. So that was a great question to finish on. Thank you so much for that.
Well, yes. Go ahead. Go ahead.
No, I was going to
Yes,
say thank you to everyone.
But don't go away, because I finish up and I got more for you. Ray, can I take over?
Yes, go ahead.
Thank you, Ray. I wrap up. I got just a little more because you have Ray. This has been fantastic. This has absolutely been mind-blowingly fantastic. I just want to tell you that. Now you might think, oh, you say that to all the speakers. Well, I do, yes, because we have mind-blowingly fantastic speakers. But I need to tell you, this has been amazing. And it makes me wish I could, I'm not anybody who ever wants to go back to the past, but if I could do my own career all over again, I would go into public health, because I just think, but let me ask you real quick, would you wear, that's the real quick things to ask you, would you wear a mask? We can make a short answer. Would you wear a mask in March Madness? Tens of thousands of people screaming and yelling. Would you wear a mask if you attended March Madness in the arena?
So when I'm a Colts season ticket holder, and I go to Purdue games, and I do wear a mask when I'm entering the arena, because you're in a line. It's the highest risk area. I think when I actually enter the arena and when I'm in my seat, I take my mask off. That's me. But I'm vaccinated, and again, I have tools. And there's lots of people out there who I wouldn't blame them for wearing a mask the whole time.
Right. For it's yes. And I have yet to have COVID, and I'm literally the only person I know who has not had COVID, and I'm all over the place. And I may be in this. Yeah, that's right.
Me too. I've not had COVID.
I'm sorry, Dennis. What?
I've not had COVID either, and I've been all over the place.
Okay, there you got two people. Now, my question is, do you recommend, as a public health officer, that people, I may be asymptomatic, that very well my pretty healthy immune system, should we just be routinely taking the test just in case we might?
No, I don't think that there's a lot of benefit to random testing. I think what I would say is make sure you're up to date on your vaccine, so you're as protected as possible. Make sure if you do have symptoms that you're testing, and then I still think it's a good idea if you're going around someone who's vulnerable to particularly vulnerable to test. As we look at Easter coming up. If you're going to go around someone who's immune compromised, it's a good idea to test so that you can protect that individual. That's where I see testing comes into play.
That's my concern is I'm gonna hope that I might be strong enough to be more a matter of well, you have absolutely hit all the right buttons tonight. I was thinking also, you said so many things I'm in such alignment with. I felt also we had leaned into a collective society. We don't see that very often, really, in our history much. But we really were. I mean, making people who could sew were sewing masks and giving them free. They weren't charging them. It was like, yeah, I've got a bunch, and that was beautiful to watch. And I've also used the argument with the issue of a national health care that we're the only free market economy in the world that doesn't have a national health care.
Yep.
Affordable Care Act is not national health care. And when you try to raise the question, people want to scream socialism right away. But I am older than you, Dr. Adams. You're just a young lad still. And you would not remember, I don't think, you will have heard the stories of what happened, what was going on with Medicare and Medicaid in 1965. And people were just linking it. This is Ronald Reagan, this is the road to socialism, beware, beware. And of course, it is not. It didn't happen. But I've used the same argument to veer away from that this would help keep a healthy workforce. And when you put it in that economic term, a national health care, you would have a healthier workforce of people at the preventive. Paul Haverson, he came to my class at Purdue, and I'm teaching next year. I'm going to ask you to come. They would love you. He has talked about the emphasis in those countries that do have national health care, have time then to talk about preventive health care. And we wait till people are sick. And it's a sick healthcare system, not a healthcare system. We, get sick and then it's great. A book that you might like a lot, that you might want to add to your reading arsenal with your digital health equity. And I want to ask you about your book when it comes out. Frank McCourt was on Morning Joe the other day, and he's a man that's making a lot of money doing, he's not the Irish Frank McCourt. I forget what he's successful at, but they had him on because of his book called The Biggest Fight, Reclaiming Liberty, Harmony, and Dignity in the Digital Age. And he talks exactly about what you were talking about, that we are the product of these companies, the Facebook, all of this, we're the product.
Yep.
We're just feeding them data 24/7. And then the algorithms that drive us crazy later that, geez, I was thinking of buying a pair of shoes, and all of a sudden my Facebook feed is, showing me. It's like, how does that work? It's scary. But we do it because, how do we live without technology? We don't want to do that. So the digital, when is it going to be the name? When will your book come out? What will it be called?
The book is called Crisis and Chaos. It's already out. You can get it on Amazon.com, and it's also on Audible. And it's actually a pretty quick read, Crisis and Chaos. Most people tell me they get through it in about 2 to 3 days. On Audible, I think it's 8 hours on Audible.
Okay, well, thank you. You could have plugged it more. And it talks about the issues that you're talking about, digital health equity and things like that.
It talks about all the lessons learned from my perspective from the pandemic, and what we need to do better in the future. So literally the conversation we had here today, how we can do better moving forward. It's not about politics and blaming one side or the other. It's about understanding that this goes beyond partisanship, and that we keep making the same mistakes because we refuse to focus on the root issues.
Yeah, and prevention. Yeah, and healthcare is not is not a deductible of $5,000 with the current health insurance situation we have right now. It is simply not. I mean, this was fantastic. Thank you very, very much. This was a great program to end on. Sue, thank you for finding Dr. Adams. And
thank you for Dr. Adams. I'm so glad I got to meet you through Paul. That's great.
And she pursued you, she was knocking your door and pursuing you like crazy, and he'll answer. So thank you for your perseverance, Sue. That was really terrific. This was a fabulous program to end our year on. Thank you very much.
Thank you, everyone. Have a wonderful night. I really appreciate it.
Thank you.